I am Dr. VilmaPacheco-Barcia, and this is Open Doors Podcast, two women scientists driven by curiosity, evidence, and compassion.
Hello, everyone, and welcome back to Open Doors, the podcast where we explore professional well-being in oncology and beyond, one conversation at a time. On this podcast, we open doors to better leadership, healthier teams, and practical tools for our professional life. Today's guest is someone whose work has transformed how we think about breast cancer, cancer care, and precision medicine worldwide.
Professor Fabrice André, MD, PhD, he's a medical oncologist at Gustave Roussy, where he heads the research division and cares for patients with breast cancer. He holds a PhD in biotechnology from Paris University, has led numerous phase 1 to 3 clinical trials, and published more than 300 peer-reviewed papers, including in Nature, New England Journal of Medicine, Lancet, and Nature Medicine. He's a pioneer in biomarker discovery, development of targeted therapies, and the implementation of high-throughput technologies in healthcare systems. He currently serves as president of the European Society for Medical Oncology, ESMO, and previously served as editor-in-chief of Annals of Oncology, guiding the journal through a period of significant growth and influence.
He was also the first chair of the ESMO Young Oncologist Committee and has shaped many of the Society's initiatives on translational research and precision medicine. Professor André, Fabrice, it's an honor to welcome you to Open Doors.
Hello, Ioanna and Vilma. It's nice to be here with you.
Thank you very much. You have been at the forefront of oncology for more than 2 decades. What first drew you into medicine and ultimately to oncology and specifically breast cancer?
Well, so maybe I'm going to disappoint you and your audience. I think, when I was at the high school, so I was doing ski racing, at quite a good level. I was number 10 in France. And then because of this, I was really fascinated by physiology, biology, other mechanism beyond performance. So because of that, I went to medical school at the beginning, really to study physiology, sport medicine. And then step by step, I learned during medical school that the specialty at that time where there was the biggest challenges, but at the time where doors were starting to be open was oncology. I know a lot of my colleagues went to oncology because they have a family history or something personal. I'm lucky enough for not having had this experience. So I entered this through a different way that was really where in medicine we could find the challenges that will maybe resolve at the end of our career, maybe 30 or 40 years after. So that was the reasoning beyond going to oncology. But then, I had an anecdote. So I went to do some ski trekking in New Zealand. And I asked one of my friends, can you please select the fellowship for myself? And in fact, he took the wrong fellowship in Gustave Roussy. So I went to Gustave Roussy by chance. Then more than 2 decades after, I'm still there.
Yeah.
So sometimes, chance or I did not plan to go there. I want to do hematological malignancy in a totally different hospital.
Meant to be.
Absolutely. And alongside your clinical work, you've built an extraordinary research career leading an 80-person team at Gustave Roussy. How do you balance the scientific curiosity of research with the day-to-day realities of caring for patients?
Well, I think, first, the research I'm doing with my team is not the same as this, very high level basic scientists, really investigate mechanism, make major discovery. The type of research we are doing is closer to clinical research and is really inspired by what the patients are telling us, So for me, it's unlikely I make a major discovery, because I'm not a basic scientist investigating mechanism. So what we are doing is just expanding the clinical observation by some molecular observation, So we say, In the past, we had database with only clinical variable. Let's add to this extensive analysis of the genome, extensive analysis of the protein, etc., etc. So what we do, we just broaden the amount of variable we investigate in each patient by adding all these molecular and cellular data. So this is what people call inductive translational research, meaning that we are doctor, we observe the patient. Some doctors, they observe the patient with clinical characteristics, and it gives a lot of important information. Some others are going to observe the patient with molecular data. At the end, it's the same process. It's about observing and using statistics to define patient population stratification factor. On that way, what we call translational research is closer to clinical research than what the highly talented basic scientists are doing in terms of mechanism.
I love the way you described a complex concept and made it easy enough for a 6-year-old person to understand it. And going back to your why, sharing with us why you entered medicine and oncology, I think curiosity probably has been the main driver. Now, as president of ESMO, at a time when oncology is growing, advancing at a very fast pace, how do you balance driving scientific progress while at the same time fostering a very supportive community in oncology for all of us and for other cancer professionals?
Yeah. So ESMO now has just reached 45,000 members. Will probably be 50,000 members, 50, across the globe. So more than 50% of the members are outside Europe, and only 30% are inside the European Union. So it means that it's truly a global society. And this global society has major challenges, that is, how to help oncologists to deliver what we call optimal care. So optimal care means treat less patient, provide less burden of treatment to the patient who are already cured, and then increase the burden of treatment, investigate new drug to the patient with hard to treat cancer. So I think this, we absolutely need to develop, cares where on one way we treat less, on another way we treat more, and it's this equilibrium that will make healthcare sustainable. We cannot always add on, If we always add on, care is not sustainable. So care are going to become sustainable if we are able to create the right rules, evidence to maybe also decrease the burden of treatment we provide to patients, and this will increase quality of life, and this will allow sustainable care. I think ESMO, ESMO, is almost a full-time job. I'm saying that for people in the future who want to become president, they have to be aware that this is almost a full-time job, because you are, president and in the board of 45 to 50,000 members. So the level of expectation is high. What I want to highlight here is that ESMO is a scientific society. So it's not, as I hear sometimes, a kind of platform for education. We provide education, we provide training, we provide dissemination for the best science, but also, ESMO is forefront to define the new standard, and this is something as president I want to really highlight. In oncology, it's a young specialty and is lacking definition, framework, standard, etc., etc. So ESMO really want to push this. I'm always surprised when I do my dosage of my cholesterol. It's interesting because it's written cutoff of positivity according to ESC. So it means that, the definition of hypercholesterolemia is given by a scientific society. We want ESMO to be there, We want to define, what is useful and what make oncology a specialty. This is a very important component of ESMO. It's not the only one, but it's a very important one that sometimes people don't see. We have released MCBS for the, to rank drug efficacy. We have released SCAT to rank genomic alteration. We are adding on the top of that new framework. It's very important. People realize there is a kind of scientific division inside ESMO.
Absolutely. And I think also something that is very important in ESMO is how you are helping through all of these guidelines, through all of this science. You're truly helping the next generation of oncologists grow. You're helping us connect across border specialties. We've had other guests. We had a guest from Mexico. He was talking about ESMO, how it has helped him shape his career alongside like the other part of the ocean. So I think this really helps young oncologists to step into leadership and shape the future of cancer care together. I think this is a very important role also.
Yes, no, you're right. We have a group, young oncologists, they can tell us which activities are important for young, and we cannot always do it, but we try to support these activities. We also have a lot of fellowship, and we are increasing now dramatically the amount of fellowship we are providing, and we give them worldwide, globally. So this is very, very important. But what I can see that the issue in oncology are really global. So oncology is about what? It's about having the right infrastructure and having the right stratification of patient. Is it a high risk? Is it a low risk? And then it's about being able to deliver drugs, even if they are expensive. And here we are all struggling for the same thing. We have to be realistic. This question of cost of drug is a global issue. So this is why ESMO, as a global organization, I think is very interesting, because when we go across the world, we see that the issues are shared everywhere. This is a reality.
Absolutely. And also, many of our listeners, I think this is a beautiful bridge to ask the next question, because many of our listeners are early career oncologists and they sometimes feel overwhelmed with data, like they need to keep up to date, keep the standards, the science, grow, learn from their mistakes, go back again, do research. So we would like to ask you, what advice would you give them about finding their own rhythm and staying connected to what matters to them in their profession?
So well, I'm trying to answer it in a concise way, because it's a very complex question. So first, most important is the patient. So what you are going to learn from the patient, has incredible value, and this you will not find it anywhere else. So it's important, because sometimes young oncologists, they want to learn guidelines, go to conference, etc. Reality is that you will learn because you see patients. This. Then I think if you want to learn, it's important that probably reviews are something important. It's very important to read reviews, read guidelines, etc. Having a good mentor is something important. Young oncologists, they need to have mentor. If they don't have mentor, they need to ask for mentors. And if after asking mentors, they don't have mentors, ESMO has a virtual mentorship program. It's very important to have mentor to discuss, where are you struggling, what concern, etc. So first level is the patient. Second level is reviews and guidelines. On the top, you need a mentor. And then more and more, it's true that you are totally right, Vilma. There are too much information. We can digest it. This is where ESMO is working deeply with the best expert in the world on what AI is going to bring us in terms of training. It's probably going to solve not solve the problem, but it's going to facilitate the way oncologists can digest all the information. But we have to explain and to train oncologists how to use these new tools that digest the information. So, and first we have to learn ourselves how to do it. So, so first level is the patient, most important. Second, high level review guideline, mentor, and going at the top looking forward with what AI can provide us. I think that are the key element. Something we are going to open at ESMO, and I really want to do it. It's something that I can see after you are mentioning you are 2 decades. Yeah, actually, it's even more, far more. The way we communicate science does not help to generate empathy. It's a big problem, We have to realize, beyond each plot, there is a human who is dying, So we need to reconcile the way to report science and the humanity. So this is something that I have put on the agenda. We are going to work very, very hard on this topic. We cannot train oncologists with Kaplan-Meier curve. This is absolutely impossible. And it's absolutely mandatory to have Kaplan-Meier curve, but we need to add something else on the top of that for people to realize that, each plot is a disaster for the family, It's something, and there is the gap is too big between these two concepts of reporting curves versus the disaster in a family. We need to reconcile these things.
Yes, Fabrice, and this is food for thought. It's really important that you touch on this topic on empathy, because I am a firm believer that we talk a lot about compassion and compassion leadership and compassion in society. And actually, because all of us involved in cancer care, we should come from the world of compassion if you think of what we're dealing with on a day-to-day basis. And yes, some of us might be involved in lab research, clinical research, but there needs to be this connection, this glue, this empathy, as you said, because how are we going to translate the data in a way that they can resonate with other humans? At the end of the day, we're all humans. Thank you so much for touching on that. You mentioned ESMO being global, growing, and obviously with the guidelines and everything, setting the tone for oncology currently and the future. We also speak in the podcast about equity. So I am going to take you on another wicked topic, which is equity in care, equity in resources. And where do you see the biggest barriers to equity in cancer care? And how do you think ESMO can, and being an international society, a global society, can help bridge these gaps?
I think, we have to be realistic. ESMO is a scientific society. So we have a public policy division that is very, very strong. But the aim of this public policy division is to collect, digest the data, the evidence that we will provide to decision maker. We are not decision maker ourselves. Okay. So this is one thing. We try to collect and to help decision makers on this question on equities, but we are not the one who are deciding. Where at the scientific level we can transform this question is what we discussed before, is first putting high in the scientific agenda all, and I know patients don't like this word, but it's all what we call de-escalation trial. De-escalation trial means better quality of life and less resources spent, for patients that are cured anyway. So we think that putting this high in the scientific agenda is going to generate investment, clinical research, attention on this topic, and that generate, and if you need less resources to treat patients, this is the first step towards some equity, but it's a scientific approach of equity. Which tools are going to help on this? Clearly, digital transformation of patient care is really the way to move forward. And on the top of that, AI is also going to be something. So we think that investigating, the decrease of treatment duration, it's a key element in patients with good outcome. Decreasing treatment duration, digitalizing and automatizing the healthcare infrastructure. If we can already push these two big topics in the scientific agenda, generate investment, generate attention, I think we are already going to go one step beyond. But we have to be realistic again. ESMO is a scientific society. We are not policy makers, a decision maker, but we can help, generating attention, putting some topic high in the scientific agenda to further generate some investment and interest in the young generation.
Thank you so much, Fabrice, for your insights. Thank you so much for your time today, for coming and sharing with us in the podcast. It was wonderful having you.
Thank you so much. An honor to meet you and have you as a guest in the podcast. Thank you so much, Fabrice.
No, thank you.
And to our listeners, keep opening doors for yourself and others.
This is Dr. Ioanna Nixon.
I am Dr. VilmaPacheco-Barcia from Open Doors Podcast.
And remember, you belong in the room.
You belong in the room.